Hey guys, so now let's talk about polycythemia. So this is a blood disorder. It's also considered a cancer, but this is the polar opposite of what we just talked about when we talked about aplastic anemia. And the other way you can kind of remember this is aplastic anemia is A, has the A at the beginning, and A means without. So I always remember that aplastic anemia is the one without all the cells, and then this one, poly, means multiple. So this is the opposite of aplastic anemia, and that there is the production and presence of too many red blood cells. So pretty much what this ends up with is you have increased number of red blood cells, white blood cells, and platelets. And this leads to a very, very big problem that you have this very thick blood and high volume. Viscosity is a fancy word they might say, of your blood cells, which can lead to very serious problems. Like the big thing we think with polycythemia, maybe think of the C that's in the middle, is that we're worried about poly-C clots. We're worried about a lot of clots. And so that's usually the biggest concern or the biggest issue with patients with polycythemia. There is a possible genetic component to this, but it's not well understood why people get this. But leads to some uncomfortable symptoms. It leads to congestion because of the excess blood cells, and can lead to some uncomfortable symptoms and some serious problems if untreated. Ooh, let's see if I can get here. All right, so what are their labs going to look like? Everything's going to be high: red blood cells, white blood cells, platelets. But something else to note is because you have too many blood cells, your body is a smart being, and it's going to try to get rid of some of these excess cells. Because it's like, hey, I've got too much of this, so I'm going to try to get rid of this. So when it tries to get rid of the excess cells, in the process of that, a byproduct of the breakdown of the cells, pretty much like the waste product of breaking down blood cells is going to be uric acid. So have a whole lot of blood cells and a whole lot of breakdown of blood cells, which leads me to having, as a result of that breakdown of blood cells, an excess of uric acid. So you want to kind of look at how this patient looks and how it makes sense based on what we said the problems are, what's going on. So they can have signs of too much volume. They have high blood pressure. And then they might even have symptoms associated with high blood pressure, like headache, vertigo, dizziness, or vision changes. Now, one thing I want to note as we're going into cardiac, at least for my school, and how we learn is that generally with hypertension, like chronic hypertension, a patient has no symptoms. Usually there's no symptoms with hypertension, but the patient that has polycythemia can have super high blood pressure because there's a lot of volume. Volume is pressure. So there's all this extra volume in their blood vessels, which leads to this excessive high blood pressure, which is why there's symptoms. But just know in general, don't think that all patients with high blood pressure have these symptoms, because it's only people that maybe have more of an acute onset or severely high blood pressure. Also, because of the excess volume, there can be bleeding because there's like rupture. So I don't know if you're from Texas, you might know what Slitterbahn is. So I love going to Slitterbahn. I love water slides. I think of, imagine if in one of those like little like tunnels and stuff where you can kind of just float around and do your thing, if there was, maybe this isn't a good thing because their tunnels are pretty pristine, but let's say that you're at somewhere that does not have the most pristine water slides. There we go. I can talk. Water slides. And imagine, in this water slide is just a whole bunch of really thick water. And it's pushing through. Eventually, more volume, more thickness leads to pressure. And then literally, like if it's, because I'm thinking water slides because of the enclosed tube, but maybe I'm like 0 for 0 today on my analogies, but this is how my brain works. So maybe it might help you, but maybe a water hose would be a much better example, but I'm not simple. I'm a complex being. But you get the point. There's effectively this, your blood vessels are these elastic tubes, and if they have too much stretch, too much pressure, they can rupture. There also can be signs of clotting or blockage problems. So you have a whole bunch of cells going towards, like, especially in the tiny like capillaries. So in like your hands, especially, you can have what do you call it? Painful burning, redness, paresthesias like numbness and tingling. It can get to more serious places like down in your legs. It can start to lead to decreased blood flow to your legs, what we call intermittent claudication. We'll talk about that soon with PAD. But it's kind of like angina pain in the legs where it's worse with activity. And they also can have angina or chest pain. There's other signs of too many cells, generalized itchy skin. The body tries to get rid of all the cells, even through the skin, or some of the byproduct of some of the stuff of the breakdown of the cells is getting through the skin. It can cause itchy skin. What's called erythromegalia, which is a redness and, like I said, painful burning of the hands. It's a whole bunch of cells in the hands. So it's going to be super painful too, because it's not just that it's like, hey, there's a bunch of blood cells here. It's a bunch of blood cells that are decreasing my blood flow. So it hurts. They can have those paresthesias, but it's going to be super red compared to when we talked about anemia. Remember, they're super pale. This patient is super red because there's lots of cells. And then also just kind of a ruddy complexion, or what's known as a plethora. And this is, of course, makes sense because there's a lot of blood cells, so there's a lot of color. There also can be signs of cell destruction or breakdown, so their liver and spleen can be enlarged, as that is how our body gets rid of those excess blood cells. So how do we manage it medically? We want to prevent them from clotting. So most people say anticoagulation, but we actually don't use anticoagulation for this. Remember, they're also at risk for bleeding. So we don't want to give them something too strong. And I think that they've just done studies, and that anticoagulation isn't necessarily the best choice here, because as a whole, we want to think about like the least invasive that we can do. So we want to stop stuff from clogging less than we want it to stop. Well, of course, we don't want it to clot either, but effectively, all we usually need to treat the high risk for clots for these patients is antiplatelets, known as aspirin. And I have other videos that talk about the difference between antiplatelets and anticoagulants. It's helpful to know. We also want them to, not make so many cells. Like, I can all day long treat the problems that are coming from too many cells, but if I don't get to the bottom of the problem and they're still making a ton of cells, I am not helping this patient. We also want to make the blood less thick. So we're going to do things like phlebotomy to remove the blood. And that means literally sometimes these patients go in, like in the beginning, they might need to do it a couple times a week, and then maintenance, maybe, every couple weeks. Maybe less or more frequently, depending. They get like, pretty much like giving a unit of blood. Now, we don't take their blood and give it to someone else. We're not doing like a blood transfusion or like a blood donation. But we are effectively just taking out. There's too much. There's too many products here. We're going to take out some. And then we also want to make the blood less thick with hydration. Think back to respiratory, where we thin stuff out. We can do the same here with our blood vessels. They have all that extra uric acid as a result of the uric acid accumulation from breaking down extra cells. So we want to give them anti-gout medications. You don't need to know the names of them yet, but it's stuff like allopurinol, or is going to probably be the main one. Usually we only use colchicine more actively when we're actively treating gout for more acutely. But usually allopurinol would probably be a drug maybe used. And then they can have itching on their skin, so we might do things like antihistamines to help make them more comfortable. What can I do as the nurse for this patient? Well, I can help perform the phlebotomy. I can encourage them to have better fluid intake, more fluid intake. It's really going to be one of my primary goals, is watching their intake and output closely, and then looking for complications. So they can go either way. They could have the bleeding from the rupture, but more than likely I need to look for clotting. So a lot of my nursing assessment and focus is going to be looking for where we can have blood clots. We can have blood clots in our legs. We can have blood clot in our heart, in our brain, in our lungs. You name it, you can get a blood clot in many places. So I need to be looking for all the signs that maybe certain organs or areas are not functioning well, or have decreased blood flow, or there's signs of a clot. So, which we will learn about in this section in cardiac. Woo! All right. So a good thing to do after doing any sort of disease process or learning about it is to think, what kind of goals would you have for this patient? So now's a good time to kind of think about, I'll give a couple as an example. What you might think of, like a goal for me for a patient with polycythemia would probably be that the patient will be free of signs. They will not have any signs of a deep vein thrombosis my shift. So you have to think about what those would look like. So I'd be looking usually with the DVT, they have unilateral or one-sided redness, swelling, and tenderness. So one of their legs is going to be bigger than the other, so I'm going to be assessing for that. Another goal that I might have for polycythemia vera might be that the patient remains free of any signs of bleeding this shift. And I usually want to specify what those would be. So I'd look for, of course, very obvious signs like an intensely decreased blood pressure, increased heart rate, any signs of course, obvious bleeding, GI bleeding or otherwise, or, no changes to their hemoglobin. But hemoglobin can take a little while to catch up when you're actively bleeding, or if it's a slow bleed. So yeah, so it's going to be stuff like that, but just kind of talking through, okay, so here's kind of some stuff I'm going to do. What would be goals that I would have if this patient was sitting right in front of me? Anyway, we made it through blood disorders. So now on to replacing what is missing, blood transfusions. I'll see you for the next one.